Welcome, a warm welcome to you indeed. Roy Noble here, and it's a great privilege to be here as a Bevan Commissioner on an auspicious occasion. Croeso cynnes i chi gyd ar ddwrnod ni wedi casglu at ein gilydd nawr am rhywbeth arbennig I rannu gyda'n gilydd. The Showcase for the Adopt and Spread program. We're supporting adoption sites as they take Bevan exemplar innovation right across Wales. I've always been intrigued with where that talent comes from. Is it innate? Are some nations better at it than others? I wondered. For instance, somebody tried to analyze the Welsh once. It was a Welshman. And he said, to measure a Welshman, you have to measure him from the neck up for a start. And Welshmen are intelligent, intellectual, and they are emotional, educated, excitable. They are cultural, they are caring, they are charismatic, vigorous, and vibrant. If they could only be if they could only be humble, they would crack it, couldn't they? Mine was the same with the British. It's a mixture because every nation is a quilt of patches, and the British are the same. What is a British person or an English person? Well, it's a person who jumps in a German car on the way home. He has a Turkish kebab or an Indian takeaway, sits on a Swedish settee, and watches an American film on a Japanese television set. So it is spread internationally. So if you are in Wales working on these and you are Welsh, fine. If you're not Welsh, but you're in Wales, that's enough. That qualifies you to have the stamp of Wales upon you and to fly our flag, all right? So then, the Bevan exemplars have been leading the National Adopt and Spread program across Wales over the last 18 months, building on the work over the last 5 years with the Bevan exemplar innovators themselves. Now, 15 of the Bevan exemplar innovators were selected to share their innovations with a new site. Over 50 new adoption sites have taken on one of these great innovations, and over 150 people have been involved in the adoption and spread of innovative ideas and innovations across Wales. Now, this work, don't forget, has taken place during COVID-19, and the participants have had to work exceptionally hard to make an impact and to ensure that we learn from the program. There is a panel of project members here with us, and they're very welcome indeed. Participated, they did, of course, in the Adopt and Spread program, and they with guests. Now, they will be ready to answer questions, the participators. So put your questions in the chat box, and the host will make sure that your question is asked and then answered, indeed. So our thanks indeed to the exemplar innovators, because I remember Julius Caesar when he supposed to have jumped off his boat and he fell, but then he got up and he said, Veni, vidi, vici. I came, I saw, and I conquered it. Perhaps these days it should be Veni, vidi, Velcro. I came, I saw, and I stuck to it. Or even better still, Veni, vidi, visa. I came, I saw, and I got a grant for it as well. Who knows? So today, enjoy yourself, be interested, be enthralled, and be inspired. It's lovely to have your company. Diolch yn fawr iawn.
Welcome to the Bevan Commission's Adopt and Spread Showcase event. We're really pleased that you're here today to listen to our feedback and to listen through the learning that we've acquired over the last 18 months. We all know that ideas alone are not enough. They don't necessarily get adopted and spread by others, even though we think they're great ideas. And so the Bevan Commission has been really exploring this in further depths during the last 18 months or so. We've worked with 13 exemplar projects, over 50 adoption sites, and over 150 people during the last 12 months. I hasten to add, which has probably been the most difficult, treacherous, and traumatic 18 months that we've all seen. Notwithstanding that, we have seen some amazing outcomes and amazing people and who have shown their commitment and great, I guess, a great opportunity to understand what makes things work. This event today will provide further details on what helps and hinders that adoption and spread. We've got tools, we've got other support that will be part of this whole program, but it's essential that we now learn more about this in order that we can move on, not only from COVID, but move on into the future and make sure that we continue to innovate and change as we do. I'm going to hand you over to your host for today, But in the meantime, make sure you tweet, make sure you enjoy the session, and overall, make sure you make that real difference.
Stirring stuff. I'm apparently the host. I hope that we can have a very kind of informal discussion about this. There's a number of videos which are going to sort of explain the background. Just for those that don't know me, I'm Chris Jones. I'm the Deputy Chief Medical Officer. And actually, before I became a bureaucrat, I was a cardiologist. But that's a long time ago now, so my knowledge is probably way out of date. But now we have a panel, as you heard. So I need to ask now the panelists to just briefly introduce themselves, and then I think there's a second video. So first panelist is Claire.
So I'm Dr. Claire Atkinson. I'm a palliative care consultant based in UHW in Cardiff and Vale. And I am the Bevan Exemplar who began the original project here in Cardiff. I've been a Bevan Fellow as well for 2 years with a remit to spread and scale.
Next on my list is Gethin.
Hi, my name is Gethin Ellis. I'm a cardiologist based at Royal Glamorgan Hospital in Cwmtaf, Morgannwg, UHB. I got a special interest in heart failure and been very fortunate in being involved in the Bevan Exemplar.
Thanks, Gethin. Next on my list is Amy. I think you're on mute.
Hi, I'm Amy. I'm a heart failure specialist nurse who works with Gethin in Royal Glamorgan Hospital in Cwmtaf, Morgannwg. I've been working on the supportive care pathway along with Gethin on our palliative physicians.
Very nice to meet you. Now, Zahir is next on my list, but he's doing something. Is that right, Claire?
Yeah, I think he's in the pacing lab, so he has every intention to join us as soon as, so something must be up, I think, in the lab. I'm sure he'll be here soon.
Pacing is one of those things that can take longer than you think.
Yeah.
My recollection from back pacing. Sian.
Hi, yes, I'm Sian Hughes, one of the palliative care nurses in Cardiff. Started work.
You just went on mute and...
Okay, is that better?
Yeah, you're a palliative care nurse in
Palliative
Cardiff.
care nurse in Cardiff, and been working on the supportive care for heart failure project for the last few years.
Very nice to meet you. And then Annette.
Hi, I'm Annette Edwards. I'm a palliative care consultant in Pembrokeshire, and I've been working, and I think Alison, I see her little names appeared. So Alison's joined us as well. She's one of the heart failure nurses. There's 2 heart failure nurses, Alison and Louise, who've been involved, and also a consultant cardiologist here as well, Dr. Nick.
Great. And then Kerry Alice.
Hi, I'm Kerry. I'm a GP trainee in Pembrokeshire and Welsh Clinical Leadership Fellow. So I've taken a year secondment to help with setting up this service. So I've been involved in some of the reporting side of it, along with Amy Beaton, who I think has joined us as well in the chat.
Okay, and then finally on our panel is Gemma.
Hi everyone, I'm Gemma Lewis-Williams. I'm one of the palliative care consultants in BCU. And my base is in Ysbyty Gwynedd in Northwest Wales. And I think me and our team are the last adopters. So yeah, we are the babies of the group.
It's all very interesting to me because I know nothing about the actual work. So it's very good to have so many people from across Wales here together. So I think we're going to hear more about it now. So Rupert, is there another video that comes in at this point?
People often think that, you know, people who are dying with cancer have the worst time. But in actual fact, often people with heart failure have a very difficult time.
Yes, it's a similar sort of suffering in a way, isn't it? But everybody's different, of course. I think when we had the first diagnosis, when he had the, I always say we because I was always there, I couldn't read the letter again. I read it because there was something wrong with every part of his heart. And how on earth he lived for nearly 10 years after that. He had everything leaking and not pumping and what have you. But he had quite a good quality of life for sort of 8 of those years.
Yeah, and at that time, there was lots of coordination between yourselves, the supportive care team, and also
amazing.
Yeah, and the heart failure team as well. So Professor Yusuf was still very much involved, and you
with decisions
knew that.
and yes.
Yeah, was that comforting and
yes.
to know?
The more I think about it, the more comforting it was. I mean, it was at the time too.
Yeah.
But some people just don't get any of that, and it's the first time I've experienced the NHS at its best.
I guess the last thing to ask is, do you think, what would Lindsay say if he was here now and he could speak about, you know, the support he had through the supportive care team?
Well, he always was very complimentary and about everything you were doing for him. He always was. The care supportive team were amazing. I recommend him and your team 100%, 150% or whatever, AA+ and all that sort of thing, because you're so dedicated and so good at what you do, and everybody benefits from your care.
And did you feel it was peaceful, the last?
Definitely. He just stopped breathing.
Yeah, he did. Well, he was a lovely man.
He was.
He was.
it's really good to see that. When I was still working up until about 11 years ago, I was very concerned about lack of access to palliative care for heart failure patients, because the final stages of heart failure are the same as for cancer, aren't they? The same mechanisms. It's the same process, isn't it? So we have a number of questions which we are going to ask each other, the panelists. And the first question, which I think is probably for Claire, is, could you tell us a bit about the supportive care pathway and the 6 elements that are within it?
Yeah, of course. So I'd been a palliative care consultant for about 10 years when I came to UHW and met Zaire Youssef, and he was worried about the fact that although lots has been developed in the last 1 to 2 decades that can really improve the longevity and the quality of life of patients with heart failure, that what was lacking was that last period of their life when patients are highly symptomatic and where they're becoming, they're suffering more and more with increasing lack of function and the burden that they experience on their caregivers, etc. And so we agreed that we would try to do something about it. And what we knew was that despite the fact that in the last 10 years, palliative care has tried to open their doors to patients with non-cancer conditions, unfortunately, the way that services are configured, designed for cancer patients, just doesn't fit with the needs of patients who have conditions like advanced heart failure. So really, we just took a blank canvas and said, right, well, what do we need to do? What do patients want? And we knew that patients wanted better symptom control, better quality of life. They wanted, instead of being a burden on the people that they loved, to instead have strengthening of those relationships. We also knew that they didn't want inappropriate prolongation of dying once they understood that they had a life-limiting condition, but also that we needed to create something that was more flexible to this unpredictable disease trajectory that these patients experience, which was resulting in basically patients often in a revolving door situation coming into hospital repeatedly because they'd often be experiencing periods of fluid overload and coming in for breathlessness, very frightened, and this sort of reinforcing situation of dependency on acute services. Whereas most of these patients wanted to maximise time at home and also therefore, if possible, die at home when that time came. So we basically talked to patients and we said, right, well, what do we need to do to improve what we're providing for you? And then all the way we've talked to them about what we're providing, and we've tried to create a service that fits patients rather than patients fitting us. We try to be flexible to their needs. We are continually using a co-speciality approach because patients actually still want to survive. They don't necessarily want to give that up, but they do want better quality of life as well. So we work hand in hand with cardiology in order to support confidence in referring to us. Cardiology remain involved all the way through, but gradually we will take on more and more of the care as they progress towards the end of their life. So we created a tailored service to each individual, addressing each individual's needs, also empowering them so that they understand their condition better, and then we can be more resource efficient. We have a clinic that is co-speciality. We go out and see patients at home. We go to where the patients are, but if they're coming up to other clinics, we'll try to see them then, because it's a struggle for them to come to clinics. So we try to make it as easy for them as we can. And to be as flexible as we can according to how they are, but we do expect patients as much as they can to let us know how they are so that we can respond rather than react. We take the patients at 1 to 2 years prognosis, last 1 to 2 years of prognosis. We know that heart failure patients, the whole trajectory is extremely expensive, about 1% of the NHS budget, but we know about half of that is spent in the last 6 months of patients' lives. So we knew that that was where we could have the biggest impact. Very much a compassion-based approach. We're always focused on the rapport. Advanced care planning, yes, but only as part of a process, not a piece of paper that we're trying to fill in. We get to know our patients and we work with them so they understand where they're at. And then advanced care planning just becomes a natural process that isn't threatening and that they don't feel that that care is being withheld. Lots of symptom control. The symptom control actually requires quite a lot of expertise that we as palliative physicians and nurses have experience with, because it's often, you know, the symptoms are moving and changing, and the patient's condition and their renal function also. So we do a lot of that. And cross-boundary, taking care out to the community, taking the expertise out to the community of both specialities, which is why we created the service around an MDT, which is co-speciality, multidisciplinary and multi-professional, so that all referrals are discussed at that point, and the ongoing progress of the patients continues to be discussed all the way till the end of their life. And that's basically what we've created. And patients have given us extremely good feedback about it. Over 90% saying that they would recommend the service to someone else in the same position as them. I think that about summarises it.
No, that's good. I mean, I don't think this is one of the questions necessarily, but for you, Claire, setting this up as the first site, you know, how easy or difficult was that? You know, how did you put this service in place? Did the health board support you in that?
At the beginning, we had a small grant from HDIG funding, actually. Zaire managed to get a very small slice of funding, about £10,000, and we had one clinic a month, and that was all. So I have to say at the beginning, you know, we literally paid for the stamps to go on the envelopes for the outpatient letters. We worked at weekends, we worked outside the lines really to get started. After about a year or so, when we'd got some outcomes, we then had support from the End of Life Board, who gave us some funding for a year, which gave us opportunity to just do a little bit more and get a few more outcomes. And then in about 2 years ago, we talked to Len Richards and told him, pitched to him and said, look, this is what we're doing. We're getting really good feedback from patients and this is what they want. And we're starting to see that this is effective and much more fitting what these patients need, but also cost effective as well, because we could start to see that we were saving bed days, keeping patients out of hospital, but not because we were withholding that, but because we were providing care in a different way. And we were starting to see cost savings, and he could see what we were doing and that it was a good idea, and he gave us funding then to take things forward. So yeah, we've had a lot of support, particularly from Len and Jonathan Gray, and of course I have been a Bevan Commission exemplar and fellow, so I've had a lot of support from the Bevan Commission as well.
But
and from my colleague Sean Hughes, who's sitting next to me, because we've been a double act, and Zaire, huge amount of support from Zaire. We've really worked together as a team.
But I suppose in what you say, you weren't actually appointed to do this. You've had to do this alongside your other work, first of all, and now it's become what you do to some extent. But
yeah.
So can I then ask everybody about how has this spread beyond just Cardiff, and how have the other sites found implementation? You know, has it been difficult to get these services off the ground in other sites? So how has the word spread? Because that's always a bit of a mystery, isn't it? And how have others adopted it? Because it's not invented there, is it? Which is one of the challenges often with innovation in one site, that others don't want to do it because it's not their creation. So how's the word spread, and how have you been able to take it on? Amy, your hand is up, Amy.
So for us in the Royal Glamorgan, Claire approached us and told us about the project, and the door was open on starting this up. We had a slightly different approach in Royal Glamorgan, mainly due to resources. I think when you're setting up a new service and trying to drive change, you need the resource and you need somebody who's willing to lead it. And I think in cardiology, we've been wanting more palliative support for our patients for a long time, having recognised the gaps in care, and we felt that we had the resource to be able to give one of our nurses, which was myself from the heart failure team, to help support this project. We had a very willing palliative care team as well who said yes when we asked them, which was a great support. So we didn't have any pushback from setting up the service. And of course, Dr. Ellis was quite keen to drive this forward as well. We were halted by COVID somewhat, but when that sort of settled down, Dr. Ellis led the way. Then we had our first clinic, and the rest is history, really.
Mm-hmm. So I like the way you said it was an open door, and that's really good, isn't it? But it's not always kind of people's experience when something is spreading from one place to another, but that's good to hear. Annette.
So I was just going to say, from my point of view, I've been worried for a long time, and not just about heart failure patients, but for those patients who had non-malignant diagnoses for whom it had been quite tricky to really know about their prognosis, but also for whom I felt that not just a medical approach was needed, that often there wasn't some simple medication that suddenly made things better again. And I was quite keen, so this is all pre-COVID, I was quite keen on the idea of having a more multidisciplinary clinics for these kind of patients, where you can see a physio and an OT and doctor and look at patients. And I say originally not just cardiac patients. And then Kerry approached me, actually. I don't know if Kerry wants to do it, and I apologise if I didn't mention Kerry when I talked about how things were in Pembrokeshire. But Kerry, who will tell a bit about what she's doing, was doing this kind of year out type thing. And she said, well, she could certainly, I think I was kind of keen to kind of take all kinds of disease groups involved, but I think Kerry understandably said, well, let's kind of think about what we can do specifically with this group. Kerry, I don't know whether you want to take on from there.
Yeah, so I think we were really fortunate in Hywel Dda, really, weren't we? Because I had some sort of dedicated time to work with the health board on different things, which was really fortunate. And I knew you, Annette, from before, didn't I? Because we'd worked together on a job. I was one of your trainees, actually. So I had heard about this project from one of the Dr. Maynard Jones, who works in the health board, and she suggested I get in touch with you, Claire. This was, gosh, almost 2 years ago now, wasn't it? And I came up to shadow you and Sian and Zahir, which is really great, because I think it was so helpful to actually see you, real life, because these things are quite difficult to discuss in an email, aren't they, and to set up. So I was fortunate to be able to do that and have some time really then to help set up the project meetings and things, which are so time consuming in the beginning. So I do think we were very fortunate to be able to have me to help with that, really.
And in what you say, the impression I'm getting is that the kind of the network that the NHS in Wales represents helped in that regard, because you heard what was going on, you knew someone who could work with you, and actually, the networking worked, didn't it?
Definitely, and I think the enthusiasm, because as I said, I'd worked with Annette before, so I knew her really well. I also knew Alison Turner, one of the heart failure nurses, really well, and so I knew that they were both really enthusiastic, and so you've got a really good chance then of it working. And then with Claire as well, having met her and the team, it felt like a really positive thing to do. Yeah.
Kerry, very interested to hear about the Swansea Bay experience.
Thanks. So in terms of our introduction, it's similar to elsewhere, that we'd got wind and heard of the service that had been developed by Claire and Zahir in Cardiff, and we were lucky to have them both come over and present at our heart failure steering group meeting. And I think What was really interesting is, what was clear is the problems that they had faced were absolutely identical to the problems that we faced and we saw up there of patients at the end stage of life with advanced heart failure, in that system of a revolving door up there, coming into hospital and having care provided in the wrong place. So up there, we tried to adopt a very similar model up there of an MDT approach up there to make sure that we were picking up the right patients to be coming up there into the service. We faced similar challenges that when we identified patients with symptomatic heart failure, our supportive care and palliative care services were not always familiar with the management of those symptoms in heart failure. So it's taken time to develop those systems. We've developed some joint clinics between myself and Idris Baker, one of our palliative care supportive care consultants. It's very difficult a lot of the time the patients are very attached to the heart failure team, that they've developed a huge link, not so much to me but to the community heart failure nurses who've been managing them week in, week out to keep things stable. And it takes a lot to transition that trust to a different team but over time, what we've seen is when we face that hurdle and you get over that hurdle, the benefits in terms of symptomatic treatment and the feedback that you get from patients straight after that is huge. We're actually addressing their problems rather than addressing what we see as being the problems as cardiologists. So the feedback has been excellent.
It's really positive. So how do people react when you talk about them being seen by palliative care? Because often that's quite a difficult moment, isn't it? They sort of realise the writing is on the wall, kind of thing. And
absolutely. I think with most of the patients I brought into the joint clinics, they know already so even though it's not the first time that we're talking about, but it's the first time that we're suggesting a joint meeting with a palliative care and supportive care consultant. But they recognise that things have been deteriorating for some time, and it's usually harder for us to have that conversation than the patients. That once you raise the concept of meeting up with a supportive care consultant who's got the skills in managing symptoms rather than simply the cardiology side of things, they're very optimistic about wanting to address those problems, because often we're not dealing with the specific problems that are meaningful to our patients. We're trying to concentrate on that life prolonging aspects of care.
And I suppose often in truth there's a stronger evidence base in favour of a palliative care intervention in terms of survival than there may be for the medical intervention of the underlying condition. And certainly that's the case for some cancers, isn't it? And so Claire, you wanted to come back in on that, and then I'd like to ask Gemma about how implementation worked in BCU as well.
So I was just going to say that one of the things we did, which I think Kerry is just alluding to too, is we kind of brought in this other concept of supportive care. So the fact that we were going to be taking these patients a bit sooner in the trajectory of the condition, so that we weren't, where the prognosis is so hard to estimate with patients who have such a variable trajectory, it's so hard for cardiology to know when to refer to palliative care. And when that conversation is so difficult then as well, it just becomes a huge barrier. So it was Zaire actually who said, you know, can we call it something else? Can we call it supportive care? And we said, well, we don't mind, we'll call it whatever you like. So we called it supportive care, and it gave us an opportunity to sort of recast the perception of what we were trying to provide, to make it easier to talk to patients about the fact that this was going to be an additional layer of support, and that we were going to be working together with cardiology. Cardiology weren't going to be sort of giving up and abandoning them. We were going to work together, but that gradually, inevitably, we would see them more and more. And that's worked really well, I think, just to give people that opportunity to just recast what we're providing. Palliative care specialists providing a supportive care model.
Is it termed supportive care in each of the sites that it's been implemented on? I'd be interested to know, but okay. Yeah. Gemma, how was it for you trying to set this up in BCU?
We're the last adopters, so Claire, I think Claire sent me and maybe my clinical director an email a few months ago, I think just to test the waters. And I was very keen, and I think as Annette sort of said, as palliative care consultants, we know that there's a huge unmet need in patients with non-malignant diagnoses, not just heart failure, respiratory and liver disease. So I think as palliative care consultants, we've always been mindful of that. And working in the acute, it's often those patients that's often the first time they meet palliative care, unfortunately, is when they come in with a decompensation. And I think, there's a huge cultural conversation that needs to take place about palliative care generally, doesn't it? So I was very keen when Claire approached me to look into this a bit further. And I think we're at a real advantage in BCU, I think, being the last adopters, because the whole conversation of what you call the service had already been done with Zahir and Claire in Cardiff, has already clearly been done in Cwmtaf and Swansea Bay. So when I approached my cardiologist to say, do you want to have a conversation with me about working together a bit more? He was very keen that I came to him, which was very reassuring. So I think that was probably my biggest win so far, was actually having engagement. The heart failure nurses, I think, breathed a sigh of relief that we were having a conversation. So those barriers initially disappear quite quickly. And I think we're very much in our infancy. We're having our first MDT literally next week. That's how new we are to this. But I think the fact that we've got open dialogue with cardiology who have seen actually the benefit in earlier referrals, so not just people that come in with decompensation, is catching them maybe a little bit earlier, or certainly within their first episode of decompensation. And I've seen a change already, even though we haven't started the service formally, because we're chatting. So I think there's huge benefits in just having a collective conversation about what's best for these patients and where each of us struggle in terms of, where we fit in and our strengths and our weaknesses as an MDT. So yeah, we're very new, but I feel that I'm at an advantage because I can learn from everybody else in Wales. So that's where we're at in BCU.
I mean, I think the second half of this discussion after the next video is more about what does this experience tell us about adopt and spread generally, and what can we learn from this success. But it is interesting, isn't it? Because all of you were concerned about these pathways and these patients anyway, and their sort of palliative care or supportive care needs. But still, it took the contact from Claire to trigger the implementation locally. So why is that? What's the role of the exemplar? Why does it need an exemplar to give you a ring and suggest you do this? Because everybody knows that it would be good for people to introduce them to supportive care early. I mean, I knew that years ago. But there's something about how this was triggered, isn't there? That Gethin.
Yeah, thanks, Chris. As you said, I think many of us in the field of heart failure have been aware for many, many years the importance of providing supportive palliative care and when to draw the line in the sand of offering invasive, intensive treatments that may make little difference to prognosis actually ultimately and may worsen symptom control. So we were well aware of that, and we'd been frustrated over many years in trying to develop an advanced service of this nature. And the work by Claire and Zahir really broke the ice, and having the Bevan label and being awarded a grant made a massive difference. Claire and Zahir have underplayed really the role they did in this, because they presented on regional and national stages, and really, the ears of our managers were caught, and that made such a big difference. So because we've been frustrated for many years, Chris, and I think that the Bevan machinery that went with that was really useful. And yes, it is money. There was some money to that, though I'm not sure if the money actually paid for everything. As Claire said, you have to do these things at weekends and on top of your other duties. But having the icebreaker effect, if you like, of Claire and Zahir's work and the Cardiff team and then having the Bevan machinery to go to that made a massive difference for us. And I think different sites will have different drivers, whether it's palliative care or whether it's cardiology. But as I think has been said already, Chris, we shouldn't be bunkered in this. We should really be working together. And it's as I said, I've been very fortunate to be involved in this, and to have colleagues who have a passionate interest in making sure that the service like this is in place to support those awful symptoms that our heart failure patients have at the end of life.
Interesting though, isn't it, that it took the Bevan experience and the Bevan support and the Bevan role and Claire's personal transformative commitment to kind of trigger it elsewhere. There's still something interesting in that, isn't there, where everybody recognised that one wanted to do this before, but somehow this has made it possible to do it.
Sadly, the drivers for many of the new developments we do need to be costed.
Yeah.
And costing quality of life and quality of death, indeed, is very hard to do. So we can look at bed days, and actually, in fairness, again, this is a very important part of Claire and Zed's work. They showed that patients wanted to die at home, were allowed to die and supported to die at home, and didn't have that trajectory of death in hospital. And so actually, there were some cost savings to be seen there, but actually, they're not always easy to measure.
And you can't realise them either, can you? So you can't take beds out.
Yeah, that may have been one of the reasons, I think.
I'm pleased, though, that the two groups that you've mentioned, the Heart Disease Implementation Group and the End of Life Care Board, both of which I look after through my division, have actually done something good here. So it's really good to hear. Kerry, you're on mute.
Sorry, I double clicked up there. I think one of the reasons for the need of the exemplar process for this project has partly been that you've needed that collaborative working between two separate teams. So you've got a cardiology team that's very much focused on making your diagnosis and getting life-prolonging treatment in, and that's very much the mindset of a heart failure team, as well as controlling symptoms. But then a palliative and supportive care team whose normal working area is different to that. So what you've really needed is that example of both teams stepping out of their comfort zones and their normal practice and showing that benefit, even though I think we both recognize that both teams would have recognized the need for it. The overlap just wasn't there, and that's where the example of this working really has taken off. And there's been such an appetite to try and repeat it elsewhere because we all recognise the need that was there.
Yeah, because I'm remembering what we used to do at end-stage heart failure. I mean, the dobutamine infusions and Isaket, and these are life-shortening things that didn't really work, are they? And they were horrible, really. Yeah. Okay, it's interesting. So, Rupert, am I right in understanding there's another video now?
Yes, there's a very short video about to play. Thank you.
Ooh. So, I mean, this is really interesting, isn't it? Because of the potential learning from this process. So one of the questions that we've got here is a bit about whether it's likely to enhance the provision of supportive or palliative care services to other specialties than cancer and other specialties than heart failure. I mean, do you think it will have an impact wider than the heart failure community? Because there's an evidence base in favour of early palliative care intervention on many fronts, isn't there? Clear.
So I would say definite yes. I think that the approach we've taken to trying to transform care in advanced heart failure, you can take exactly the same principles and apply it to renal, respiratory, advanced liver disease. And I think that, in fact, that's something we're going to be looking at doing now in Cardiff and Vale. We are just actually about to appoint a clinical fellow to support innovation here in Cardiff and Vale to look at that very thing. It'll be different for different conditions, but for example, in chronic renal failure, where the driver to dialysis is often based on symptoms, severity and prevalence of symptoms, that's usually the defining point of starting dialysis. So it seems to me quite straightforward that if we were adopting a similar approach, seeing patients sooner, managing their symptoms better, helping patients understand what's happening to them, which is really important, then you can change the direction of what happens to them and potentially delay going on to dialysis or avoiding dialysis at all, which is then going to correlate to better patient experience, better quality of life, and cost savings. So I think, you can look at the same, it just, in my mind, it's intuitive to do the same thing. And palliative care as a speciality, we keep our light under a bushel, really. And that's historical from the fact that for a long time we're a very small speciality with a very small amount of funding. With a remit to help cancer, we evolved from voluntary sector, charity organisation money a lot of the time. But we have a lot of skill in communication, helping patients, supporting patients, expertise in symptom control. And I think, and also this ability to work with another speciality and, really interface and work together, that is so powerful. That you're not taking patients over, you're not trying to do the job of the other speciality, you're embracing that expertise and bringing yours together with it, and then the patients benefit so much from that. And as Kerry was saying, they have such strong relationships with their referring team. You don't want to be trying to take that over, you want to work together, and then you can transition them into palliative care. So in my mind, a resounding yes. And I hope in a year's time, when my clinical fellow has hopefully done 12 months of excellent work, we'll be able to answer some of those questions for you.
Annette, I think you're on mute as well.
That's the most commonly said phrase at the moment. Yeah, so when I was first it wasn't just cardiac patients at all.
Annette, it's quite difficult to hear you. I think it's because you're chatting off slightly right.
What have I done?
I couldn't hear you very well, I think.
Okay, is that better?
Yes, I think so.
Yeah. So when I was first interested, before I had a chat with Kerry, I was very much looking at the broader group of patients that I wanted to kind of do more work with. So do I think it will progress to other specialties? Definitely. I think as a specialty, in terms of palliative care, we've got to increasingly work more alongside other specialties. And I think we are definitely doing that. I think there's room for kind of setting up the MDT type approach with a few other specialties and linking in there most definitely. What I will say though, and what does worry me a bit, is purely, so locally, I'm a lone consultant. I'm the only consultant in Pembrokeshire for palliative care. our palliative care CNS team is really small, and that is a concern, because if you've got one person on holiday, which you are allowed to take a holiday, you only need to have one person off sick, and then you've got one CNS covering the whole of Pembrokeshire. So if we're going to increase the workload for the general palliative care team, we have not got the capacity to do that. And this is what worries me, and we need to kind of think about ways of doing things a bit differently, and how much of that is educating and upskilling some of the specialist nurses, but they're limited. So we've got 2 heart failure CNSs again for the whole of Pembrokeshire, and they struggle anyway in terms of their caseload. So to keep on all the patients in advanced disease again is really tricky. So I think theoretically, yes, I think it's really, really important. I think we've got a huge amount to offer, but it's got to be matched by some commitments in terms of staffing.
I suppose that leads on to 2 questions that were on my mind to ask you. One was, has this very positive experience enabled you to make the case for these services to be placed on a more sustainable footing within your own health board? Have you been able to take evidence to your executive type colleagues and the people who are, I guess, making the decisions? That was one question. And I suppose the other question was about the specialist nature of the work. Does it need to be a palliative care specialist who leads this, or is there a train the trainer type opportunity where others who are more generalists can learn some of the skills? Claire, I think you're on mute too. Still on mute.
Sorry, I have to answer that question. I really believe that if you want the best of the care that can be provided at that period of someone's life, then you need those who are most expert and most experienced in doing that. And I just think palliative care do that best. When I've been to Q&A meetings with cardiology and that question is asked, I say, well, actually, I have managed an MI in the past. Would you like me to manage yours? And the answer is, of course, no.
but
if you want the best results, if you want the most cost-effective outcomes, if you want the best patient experience, you need those who have the best skill at doing that, and that is palliative care. And I think when you look at the cost efficacy, in 2020 in Cardiff and Vale, there was myself and one CNS. We cost 100k. That's all we cut. Well, a bit less than that, about 90k. We saved in bed admission days approximately 2 million. So every referral coming to us, we save between 10 and 16,000 pounds. So we have proven our worth, but it's a bit like changing your energy provider to Octopus. It is less expensive, but then people say, well, where's the money? Well, it's because you're having to spend less, but we are worth every penny. But we do need the investment. We're a small specialty. We don't have resource to be able to just, oh yes, let's take on more. We do it out of the goodness of our hearts. I have done for years, of course, we'll just see one more person, but we actually need to have our skill and our expertise recognised with better investment, and we will reward it 100 times.
You're sounding like a cardiologist. But actually cardiology is going on a slightly different journey in some ways, because actually increasingly in cardiology, we're talking about less dependence on cardiologists, probably more capability in primary care and the community. Patients who previously were in hospitals now being managed, locally. So there is something, isn't there, about the overall, the greater good and the best overall impact to a wider group of people.
I think so, and I think when you talk to GPs, these patients have become hugely complex, have become more and more complex, and actually have been managed in secondary care. GPs are scared to take on that management, and a team who can take that management out, who aren't scared by a creatinine of 500, you know, or somebody who's decompensating, who normally would be shot into hospital, but we say, hey, it's okay, you know, look, why don't we try this instead of little Oxynorm, and we could start a subcut infusion of furosemide at home, because we've talked with the family and the patient, and they understand that they've got a life-limiting prognosis and they don't want to spend the last 2 weeks in hospital, and this could be it. GPs find it hugely helpful for us to be involved, and so do the district nurses, because we're, you know, not just handing it over and expecting them to manage something that they haven't got the skill to manage. But when we're taking the expertise of cardiology out, you know, I'm not a cardiologist, but I can take that expertise out with my expertise, and then you can manage it out there, linking into the GPs, and that's good cross-boundary working, and it works, and everybody is glad to do it, because ultimately we're all in healthcare for patients, and that's the driver. You know, ultimately it's not very, nobody on this call is anything to do with money. All we really care about is patients and patient experience, patient quality of life, you know, just as we care if it was our mother, you know. So
Zahir, welcome. I'm just going to turn to Gethin, and then I will come to you if I may, because adopt and spread is characteristically difficult in Wales, not just in Wales, I don't think, but not invented here as something of a syndrome. But this has obviously been massively successful. So is there something about the learning from this experience, isn't there, Gethin?
Well, I just wanted to endorse the point made by Claire about the requirement for specialty skills in managing patients with advanced heart failure that the palliative care team bring to the table, and that this should be done jointly. And that is the beauty of this exemplar, that we've adopted a service that it relies on two teams that haven't worked together well enough in the past. And I would also make this point, which applies, I think, to all the other conditions which have clearly palliative care needs, is the requirement for patient identification. And that's really where we feel the specialist heart failure consultant is important, is identifying the patients that would benefit from this service jointly with the palliative care team. And I'll also make this small point of our experience, which I think has been shared in other centres, is the importance of having that heart failure specialist nurse. That's been crucial to the way our services run. And Chris, as you said, a lot of our services are being moved back to the community, not just palliative care, but other parts of cardiac services. And it does rely on having these specialist nurses to support the cardiologists. I want to just make that point as well.
Zahir, it's nice to see you. Difficult pacing. We were just saying actually that you know, this is, everybody who's spoken in the other sites kind of recognised the need for palliative or supportive care in either heart failure or other non-cancer conditions, but somehow the services weren't in place until this leadership, kind of till your leadership with Claire came to the fore. So there is something about what was the role of you guys as the kind of pioneers of this when everybody recognised the need already? And also colleagues have said that they feel that this will facilitate further spread of palliative or supportive care to other non-cancer areas as well. So it seems to have played into an area where everybody was really receptive and just shown what's possible in a way that actually may have repercussions much more widely, which is really interesting. I don't know if you want to comment on that. It's a broader point than.
No, I completely agree. I mean, I think one of the reasons, there are several reasons why I think this has flown. I think the first thing is that heart failure is a very common condition. And, you know, we as cardiologists and heart failure specialists, heart failure nurses, get to know patients throughout their whole journey. So it's not, you know, a very quick fix angioplasty out type disease. This is a cardiology chronic condition. So we get to know the patients and their families over many, many years. And we all face this problem where, there comes a point where there is nothing more that we have to offer these patients from a cardiology perspective. We've reached the ceiling of care. And then, there was a massive void in what we can do for these patients, what we can offer for these patients. And, for me, one of the drivers was you see the patient in clinic, and you've seen the patient bounce in and out of hospital. What a dreadful time they had in hospital. They really have a feeling no better. You have a conversation with the patient in clinic saying, look, we're going to do everything we can to try and keep you out of hospital. 2 weeks later, they've just spent, 18 hours in the MAU department because, we didn't have the facilities to keep them at home. And it's really embarrassing to go and see the patient and face the patient and the family. So, there were drivers then. This was a common condition. It's happening quite often. And so that was one reason. The second reason, I think, was that I think the timing is right. Palliative care, have realized that actually it's not all about cancer, and they've opened their eyes to non-cancer areas. So, before Marie Curie funding was dedicated specific, I think there was a parliamentary order that said all the funding was only for cancer patients. Now, correct me if I'm wrong, but I think that's actually changed now. So there has been a sea of change in the palliative care arena as well in looking after non-cancer patients. They had some experience from motor neurone disease and other areas, but heart failure is quite a big beast. And then the third reason I think it's worked is that we do actually have interventions that we can offer these patients in the community. So it's not, when the patients come into hospital, we give them intravenous diuretics. Well, we can actually emulate that in the community with subcutaneous diuretics. It's not exactly the same, but it's really a step down towards these patients, and facilitating the end of life experience, really. So I think there were many reasons why this worked really well. I think, clearly has a passion for non-cancer palliative care, and talking through patients about that, and it just seemed to work. And in terms of spreading it out, I think you've seen the data, very, very powerful. When I first showed it to Gethin and Kerry, they basically said, look, there's a gap in our services as well. This data is amazing. We want to take it on. And as you said, other areas as well. You can actually roll this out to nephrology. Subcutaneous diuretics will work in nephrology patients as well. Now, it's not going to be as good as dialysis, but it's a step down towards the end of life pathway. So there are lots and lots of opportunities to both scale laterally and upwards as well.
Interesting. I remember starting patients with heart failure on Oromorph, but always recognizing it wasn't going to relieve the breathlessness of pulmonary edema. Annette.
So I was going to say, Amy's had a hand longer than me, so I think she should go first.
Yeah, I'm sorry. I didn't see that. Amy, I apologise.
That's quite all right. I just wanted to sort of champion Claire's point really about the importance of the palliative care physician leading on these type of projects. As you've asked about, are there other specialities? Can it be, brought out across different areas like respiratory? I think from our team, we've been a long time trying to improve the palliative experience of our patients, and as a team with an interest, we were still having a big gap in terms of the care that they were receiving. And you've only got to sit in a joint clinic with a palliative care consultant to realise the difference in what they bring to the table. It really is a very specialist area. And I don't think that many people would be able to do it very well from other specialities unless they've really got the passion or the drive behind it. So yeah, just to say that the palliative care leading this type of project, I think is integral to its success, really.
Yeah, I mean, I think that, there's always a bit of a debate, isn't there, about the extent to which you should rely on a specialty compared to making everyone better able to manage end-of-life care. So there is some kind of balance to be struck, because there are so many people clearly who are passing away in predictable circumstances. They can't all have a specialist palliative care input, I guess. So there is.
Sorry to interrupt, Chris, but I think that is true. But I also think palliative care, because we've had a very small resource for a long time, what we've done is we've said, no, everyone else can do it. You know, everyone's business is dying, which is true. But we've kind of forgotten that actually, do you know what? Yes, it's like, you know, your GP can manage your hypertension. But actually, when push comes to shove, you know, if you really want the best, you go to a cardiologist, don't you? So it's you know, I think that yes, some people can do it, but I just think if you, as I said before, I think if you want it done really well to get the best outcomes, you need the best team.
Yeah. So anything else that anybody would like to? Oh, Alison.
Yes. Oh. Alison.
Sorry, I think I thought Annette was going to talk first, but
I'll follow up for you.
I know I'm not on the panel, but I just thought there were a couple of things that I wouldn't mind saying. If that's
on
okay.
the panel, I'm sorry.
Basically, from a heart failure nurse's perspective, we have kind of muddled through to date, I think, with what we do with our palliative patients. You know, we did have a system in place to refer them to district nurses, but it was kind of, well, it was very time consuming to start with, to be able to do all the individual referrals to OT, to referral to a physio, referral to palliative care, referral to a district nurse, get equipment, that kind of thing. So the benefit from our point of view is just to having had that kind of structured approach. And I don't know how measurable that is, because we kind of got the job done to a certain extent before, but to be able to benchmark that against what we've got, or the potential of what we've got now, is just unbelievably different. So I think, again, the other thing that probably might not have been mentioned much is that the heart failure patients rarely come with just heart failure. So looking at all the other diseases, and that's where we can do our heart failure bit, and we like doing our heart failure bit. We pull in as much renal as we can with the kind of proactive treatments that we do, but it's pulling that together when we can recognise the ceiling of care. We're kind of good at that bit, but it's actually carrying on that care, which is the bit that has been most valuable from my point of view. And hopefully with this kind of transforming of pathways, we can kind of embrace that into heart failure. But also, like Annette said, there's two of us. We're going to start, we prescribe. We're going to be taking on all these active, proactive heart failure management strategies with the SGLT2s, the early Entresto starts, all the active heart failure thing. We need palliative care for the palliative care bit of what we do. And at the end, other than decompensation, what else are we doing as heart failure? We've recognised it. We know we can treat decompensation, and we would certainly be there to support that element. But the bigger picture stuff is what our patients have benefited from, like the qualities of what palliative care can bring. So we can a bit of a step back, and everyone else takes a bit of a step forward. It's not a we hand over to you and we run away. It's this joint approach has just been phenomenal.
And we've also, Alison, because we've had OT involvement, which has been really useful, because there are certain approaches in terms of the fatigue management and the goal setting and the breathlessness and all that kind of stuff, that actually an OT that's been really, really helpful. So just people, when they're looking at services, I would kind of look at what OT support you can get as well, because that's great. Can I just make a note for the North Wales lot who are just starting, Gemma? One of the challenges for us is that we set up this idea, and I say our ideas came before COVID, and then COVID struck. Was this concept that we would have this clinic. We originally wanted the clinic where we're going to have the OT and physio there as well, and our charities and people there as well. Pembrokeshire is really rural, and I'm sure North Wales is really rural. And so you end up covering a large area, and actually we've never brought all the patients into clinic in Haverfordwest. And if you were going to make, so what ended up happening with COVID was we did some, so the heart failure nurses have got some distant clinics anyway. So as things moved on a bit, we managed to go into some of their clinics around the country, around the county. But we did a lot more me going to the home, even if in other situations it wouldn't have needed a home visit, if that makes sense. And it's just to say it is really time consuming. And just thinking about the amount of time, because I can drive, do a home visit, come back and dictate a letter and make a few referrals and things, and that could be like a whole session. So I think that's the thing we need to think of, is how you make it cost effective going on, but particularly in such a rural setting, because to get everyone to come to you to clinic just wasn't going to, I mean, we couldn't do it anyway because of COVID, but even looking forward, I'm still not sure we would necessarily go back that way, even though it would be a lot more time effective. So I think we need to have a little think about what we're going to do as well. Thank you.
You're on mute, Gemma.
I've done it now, haven't I? Sorry. I'm sort of anticipating the challenges of rurality already. So to start with, I guess North West Wales has 4 separate counties, Anglesey, Arfon, which is where Ysbyty Gwynedd is based, and then Dwyfor and Meirionnydd, which are the real rural parts of North West Wales. And to begin with, I'm just focusing on 2 counties that are geographically closer to my main hospital site. To give me an idea of whether that will work in terms of getting patients to Ysbyty Gwynedd, and in terms of actual scale, so how many patients in those 2 counties are potentially candidates for outpatient review in our supportive care clinic, and then that will give me an idea of then the numbers in that population of North West Wales and how I'm going to manage the more rural patients. I know Care the Elderly have got some models that they have used, so maybe that I need to have a conversation with Care the Elderly, how they've done their rural clinics. So I think I'm going to be having further conversations going forward in preparation for Dwyfor and Meirionnydd, because like you say, Annette, it's going to be potentially half a day, 1 session, potentially seeing 1 patient when I've got a 2-hour journey to Harlech and then a 2-hour journey back to Bangor. So I think, yeah, that's going to be one of my challenges. I'm sure Chris, you'll be talking about this later in terms of each site, but yeah, I'm almost anticipating challenges already and potential solutions. But yeah, I'm quite glad I've got other people in Wales that I can, we can share ideas from.
No, it's lovely to see you sort of offering to support each other, really, and it's like a natural clinical network, isn't it, that's developed. We're going to have to wind up in a moment. Is there here final word really to you? I suppose there's a report I gather going to come out in the summer. I think that was on one of the slides or something that I've seen, and I would just be really interested to sort of understand to what extent elements of this can be translated into other situations, because spreading best practice is hard normally. But anyway,
sure. Yeah, no, thank you. So there was just a couple of things I was going to mention. Actually, it may have been diluted by some of the other speakers, but I think it is important to realise that the heart failure nurses are really important in this, and they've been doing a lot of palliative care in the past. We don't have enough heart failure nurses, so we're really struggling with on that end, the heart failure palliative care or supportive care that has been offered in these patients isn't just palliative care. There's a lot to it. It's palliative care with an emphasis on heart failure management. So there has been bilateral learning, and over the last 3 or 4 years, I've learned a huge amount. Now in my own communications with the patients, we're talking about transitioning of their care. There's words that I've learned, advanced care directives, and I don't actually broach that, but there are skills and mechanisms which I'm aware of, and we can and can tap into. When we have our MDTs, over the last couple of years now, I can see that CLEAR has also upskilled in terms of heart failure management, and when to introduce metolazone, when to hold off the metolazone on these patients, and so there's been joint learning. So it's not just palliative care. I think palliative care physicians need to realize that there is actually a learning process involved in the delivery of this care model. But I think it's eminently scalable and it's eminently spreadable as well. And we're just going through the paper at the moment that we're writing up. Claire's got the latest draft. The data is absolutely outstanding. I mean, p-values are huge, and and we're really seeing the benefits for a service that we went out to benefit patients. Our objective wasn't to save money. It was actually to try and do the right thing for patients, and it just so happens that it's actually incredibly cost effective.
Most things like that are, I think, in the end. But it does sound like a wonderful service, I have to say. Claire, maybe final word to you, actually. You put your hand up.
Can I always like the final word? Just to reiterate what Zaya has said, that basically, we set out to help the patients. Compassion was the absolute fundamental foundation to what we were trying to do, and to relieve suffering. And but it just happens that, as Zahir has said, the progressive learning, and over 5 years we've shown an increasing benefit in reduction of hospital bed days, and have now even on index data showed significance. So at the end of the day, what's the ultimate way to spread and scale? Have really, really good data and service that patients really, really want. It sells itself.
Well, I think it sounds wonderful. It's been a pleasure to listen to the story. I had no idea actually this had been going on, even though my teams have been funding it and supporting it and known all about it clearly. But thank you very much for your time now. So I think we've kind of had the discussion that's been a really nice discussion to have. And Rupa, do you have yet another video to sort of finish us off, as it were?